Well, greetings, everyone, and welcome to the EKG case for the week of June 17th, 2013. This week's case was sent to us by Dr. Josh Reynolds, who is a former graduate of our residency program. And after finishing his residency, we were unable to convince him to stay in Baltimore. He went out to Pittsburgh to do a research fellowship, which is a fantastic institution. He's done a lot of research even before residency in emergency cardiology and invasive cardiology. And anyway, he's done some really great work out there and just recently moved up to Michigan. And I'm mentioning all this because I know you are going to be seeing his name in a lot of great articles and textbook chapters and talks. He's actually published some great stuff already. Anyway, Josh sent this from Pittsburgh. He and one of his colleagues were taking care of a patient, 74-year-old man that came in presenting with some atypical chest pain, the details of which I don't know. He simply said that there were some concerning factors in his history and some that were a little bit off. Anyway, this guy's got a history of cardiac disease. He's got stents. And a big concern here, he was recently taken off of his aspirin and clopidogrel in preparation for spinal surgery. He had the surgery and had not yet resumed taking these medications. Now, that's a red flag. We know that clopidogrel can be helpful after stents, but we also know that when patients are taken off of clopidogrel, there tends to be this rebound phenomenon in terms of acute thrombosis. I'm not really sure why that happens. I don't know if anybody knows why that happens, but it's almost as if patients are at higher risk when they abruptly come off clopidogrel than before they started the clopidogrel in the first place. Anyway, all of that is meant to say that this is a red flag. So anyway, we move forward. We get a 12-lead EKG on this guy, and he has sinus tachycardia with a left bundle branch block pattern. Now, let me move forward and just talk about his baseline 12-lead for a second, because this is an opportunity to review the Scarbosa criteria and also the definition of how we define left bundle branch block pattern. So how do you define a left bundle branch block pattern? Well, you need to have a little r deep S wave in V1, V2, and V3. Sometimes you don't even have an R wave, but there has to be a deep wide S wave in those leads. Typically, you'll also have a leftward axis, downgoing QRS complex in AVF. And also, left bundle branch block is such a powerful leftward force that you really shouldn't have any Q waves in the lateral lead, especially 1 AVL, V6, maybe V5 also. Notice in this case, there are no Q waves, and that's typical for a left bundle. If you did see Q waves, it wouldn't actually qualify as a true left bundle. You'd have to call it a non-specific conduction delay. But anyway, this is a true left bundle branch block pattern. And the other important thing to keep in mind is the Scarbosa criteria. So back in 1996, a really smart cardiologist by the name of Elena Scarbosa published a few criteria saying that you can sometimes diagnose MI in the presence of a left bundle branch block pattern, which supposedly at the time was going to kill the dogma that everybody was teaching and learning, that you can't diagnose MI in the presence of a left bundle. I say supposedly because there's a lot of people who still live by that dogma and think that a left bundle branch block pattern means you can't interpret ischemia. And while there's a lot of good research, validated research, that says that those people are wrong and need to pick up a journal and read, for gosh sakes. But anyway, I'll get off my soapbox here. So there's a rule of appropriate discordance that Dr. Scarbosa brought to our attention. The rule of appropriate discordance simply means that when a person's got a left bundle branch block pattern, there is a discordance between the QRS complex and the J point. So in all of the leads that I'm circling, when the QRS primarily goes upwards, the J point's a little bit below the baseline. QRS goes upwards and the J point is a little bit below the baseline. In all of the leads where the QRS goes downwards, the J point should be a little bit above the baseline. Or isoelectric, like in these two leads, that's okay. But the key point here is that you should never have a QRS that goes up and the J point is above the baseline. You should never have a QRS that goes down and the J point is below the baseline. All right, so you should never have concordance of the J point or ST segment and the QRS complex. So those are the two most important of the Scarbosa criteria. There's a third one, which is a bit less specific. I'm not going to talk about at this moment. Let's go back a second to the 12-lead EKG that Josh and his colleague got. And what you see here is a typical left bundle branch block pattern. There's sinus tachycardia. And you'll notice that, everywhere the QRS goes up, the J point's a little bit below the baseline. Everywhere the QRS goes down, the J point's a little bit above the baseline. But there's some funky stuff, funky to use the technical term, going on in the lateral leads. All right, what exactly is going on out there? Well, what you see is, take a look at those T waves. First of all, it's almost like tombstone type of T waves. And whenever you see tombstones, you never want to end up in that, having your patient under a tombstone. RIP is rest in peace for those international folks out there. You don't want to, tombstones should scare you. That's the bottom line. The other thing that you see out here, you don't technically see Scarbosa criteria because where the QRS is going up, there's really no ST elevation. There's maybe a tiny bit right there, but it's really only in that one beat, so we can't really call it. But you know what? I don't know if I'm making too much of this, but it kind of looks to me like you're seeing a bit of a checkmark sign. You know, is that checkmark coming back to haunt us once again? You know, essentially, it's what I had referred to before as the QRT sign. There's no S wave in leads V5 and V6. You just got that QRS going up, and then rather than having any ST segment, it just shoots right out. I drew it with a little ST elevation. I'm cheating, but it comes right down, and then without any ST segment, without any warning, boom, right out into the T wave. And again, like I said last time, if you put your ear close to the microphone, the speaker, you might actually hear the QRS come down, and you'll actually hear the boom as it shoots out into the T wave. Listen carefully, and you'll hear that boom. So that's that QRT sign, or what I refer to as the checkmark sign. And I think that's really abnormal. It's something worth making a big deal about. Anyway, that's not part of the Scarbosa criteria, but it sure as heck makes me worry. It sure as heck made Josh and his colleagues worry, especially when you take a look at the baseline 12 lead, where those T waves are not tombstones. There's no check mark or QRT sign. So they were worried enough to activate the cath lab, and cardiology wanted to get a troponin because it didn't meet formal criteria, so they obliged. They got a troponin, and the troponin is 4, normal being way less than 1. All right. So cardiology said, well, just admit him for medical management. So they did that, and the next troponin was 7. It's not a good thing when it's nearly doubling. So then the patient went for cath, and sure enough, at cath, the patient had in-stent thrombosis of the mid-LAD, 100%. All right, so there's a couple of things that perhaps shouldn't surprise you. Number one, here's a patient who just came off clopidogrel, didn't get restarted. That's a red flag. And then secondly, you've got that check mark or the QRT sign. You've got tombstone-looking T waves, and those should concern you even if it's a left bundle, and those are clearly abnormal compared to the baseline. So just a few take-home points here. You can sometimes read an MI in the presence of a left bundle. So don't just look at a patient's EKG and say, well, there's a left bundle, so I'm going to shut my eyes and not worry about ischemia. Even with the left bundle, if you keep your eyes open and look carefully, you will notice some changes that really make you worry. Tombstone T waves, the checkmark sign, and of course, you've always got to know the Scarbosa criteria. Know these simple things. You know, keep your eyes open, take a look for subtleties, and you just might save lives, which is exactly what Josh and his colleagues did here. The last thing you want to do is to just sit on a patient, especially a patient with a left bundle who's already got significant problems. You don't want to sit on these patients and just let them continue to infarct myocytes. So remember, reading EKGs can save lives if you read them well. Take a look at those 12 leads. Pay attention. Talk to you next week. Bye for now.